Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Hi, George. It's Tuesday afternoon. It's a beautiful afternoon in Virginia. And we have a very, very special guest, Dr. Sabrina Braham, will be joining us today. And we're going to be talking about innovation in pediatric medicine.
Today, we're going to do it a little differently. Usually, we're the guys doing the questions. Sabrina is going to be questioning us. Could you imagine? And could you also imagine I'm actually working on Tuesday? So I took off some time to meet with Sabrina so we don't have to reschedule. So take it away.
Great. So welcome, Sabrina, and you'll be our first guest host. Take it away.
Amazing. So I should probably start with how I found you guys, right? And maybe a little bit about why I reached out. And let's start here. So when I left my practice, I was in community practice for 12 years. And when I left my practice to think about how we could reimagine how we deliver child health, I needed to really understand how, let me start that over again. Okay.
Tell us why you left.
Yeah. So why did I leave? So, can we do that one later?
Okay.
Yeah.
Let's start from the beginning.
Let's just start. Why don't we just start with questions?
Yes.
You guys, and then we can kind of does that work?
Yes.
Yeah. So I've admired your work, both of you. Your podcast is probably some of the best programming for pediatricians that I've come across. And I'm curious, how did the two of you start the Pediatric Lounge?
Well, thank you. The Pediatric Lounge was a dare and a joke. So our good friend, Dr. J. Michael Connors, the pediatric emergency physician, kept complaining about how we are all pixie dust, cockroaches, and we're all going to be working in Walmart as greeters soon if we don't change our ways. And I said, well, let's quit complaining. Let's do something about it. And Mick said, well, what do you suggest? I said, well, we lost our voices. Who has a voice in healthcare today? The legislators that are mostly lawyers and don't have a clue as to what they're doing. And the hospital administrators who are probably a little less clueless than your legislator. And the doctors don't get together. We don't get out of our offices. We don't break bread together. We don't sit in the doctor's lounge together. And that's why they're winning the battle and no one hears our voice.
Yeah, and I was always upset that I would go to conferences and I'd listen in on the different practice management conferences and everybody's talking about doom and gloom stuff. And I went up to a lot of the people that organize the conferences and I said, you guys have a captive audience. Instead of doing the doom and gloom story, why don't you share good stories? And nobody ever did. So then I met Herb and we decided, let's go to a place where the doctors used to go to talk about things and let's elevate great physicians and great stories. Hence, the Pediatric Lounge was born, a place to elevate great physicians.
I love that. And I think the piece about it that's also really important is that you guys, the content of your interviews really gives practicing pediatricians actionable information about how they can improve their practices and improve their work-life balance. And so how did you come to decide on sorry guys, I need to just
it's okay, just chill. It's the conversations in the Pediatric Lounge.
I don't usually record video and
it's okay, we're just talking
on camera. Okay, so we'll just relax. All right, so how long have you been doing the podcast?
Almost a year now in May.
And what if you had to sort of nutshell what you've learned, high level, what do you think are the take-home points?
I learned that there's a lot of great physicians out there that are the best kept secret in the world, and nobody knows about them because they're doing a great job every single day. And all you hear about is the bad stories, and I'm tired of the stories.
What about you, Herb?
I think that there's some phenomenal old school physicians out there. People that go home and they worry about their patients, and they go and read at night when they get home. They call their friends, they ask their friends around. I've always thought of physicians as firefighters or police officers. We're brotherhood, and we go home and we worry about our patients. That's a good physician. There is no clock in medicine. The clock is always running. So it might be 5 o'clock, but I'm still worrying about that kid that I'm sure about their diagnosis and couldn't get him to the specialist. And we hear that story over and over, and the empathy and the compassion and the joy that pediatricians get from being part of their community and the relationships that they built. I thought honestly that had all been lost because of corporate medicine.
So I could not agree with you more. I think what I experienced coming out of my practice is that you are exactly right on that there are incredible pediatricians out there. I happen to be of the opinion, and I know that you probably share this, that pediatricians are among the best and most conscientious physicians around, and we really truly own our patients. But what I experienced is that it's increasingly difficult in our system to really care for patients, right? So the quote that I always use is that it felt like I would get out of bed and want to give 400% to my patients, and they would still leave the office like feeling like they'd only gotten 10% of that effort.
Why is that?
Well, so that's the question I have for you guys. So what I've spent the last couple of years doing is trying to understand what that friction is. What is the friction in the system that makes it feel like people, I mean, in life, if you look at any industry, you won't find people who are more dedicated to their craft than pediatricians. I mean, really mission-driven people. And so how is it that if you look at the metrics for pediatric outcomes, we're not doing great? And so the conclusion I came to is that it's this friction in the system. So then what's the friction? I have some thoughts, but I'm curious what you guys think.
I want to hear your thoughts. I'll tell you the answer.
Well,
I'll tell you my thoughts. Okay.
No, let her tell us her thoughts, Herb.
All right.
So I came up with this concept of the pediatric paradox. And basically it describes this idea that we all say we care about kids, but our system's not set up to care for them. And more specifically, what that means is that the goals of pediatrics, the goals of child health, the goals of families are long-term, right? Thriving, flourishing, functioning well in school, functioning well in the world. And these are all, these are not outcomes that are incentivized by the fee-for-service system that we all exist in, right? And so to the extent that you are operating in that environment, it's going to be always really hard to do the quality of work that you want to do, given the constraints, right? Because you need to have, even before COVID, we needed to have visits instead of making it more convenient for families doing a video or a phone call, when we know that would be just as good, for instance, for counseling. So that's the first thing, is the sort of misalignment in how we pay for healthcare. And I think part of that is because pediatrics is really two things. It's public health and it's medicine, right? And so all the public health pieces that in most other countries are paid for by the government, pediatricians are doing, and most people don't realize we're doing that, right? It's the dietary counseling, it's developmental counseling, it's sort of all of the preventive stuff that we do. That's how I think about it. And then you sort of look a little bit more closely at our payer system, and we, because of the fact that we have employer-based insurance, and we have this churn where patients or families are changing insurance every 2 to 3 years, there's even less incentive for any one payer to care about long-term outcomes. And so for that reason, we have another paradox, which is that we spend the least during a period of time when we are likely to have the longest and most significant impact in population health. So I guess my answer to that question is really that it's just a series of misalignments. And that's what results in this friction.
I could see that.
You're not buying it.
Halfway. I'm buying half of it. Okay, that's the academic answer. All right, I'll tell you the practical answer. You know, everybody blames it on fee for service and all that kind of stuff. They don't even know why they blame it on fee for service. Why are you blaming it on fee for service?
Are you asking me?
Yeah.
Well, no, let me hear your thoughts, George, and then
My
I'll
thoughts
give you
are,
my thoughts.
yes, they should pay for the developmental screening. A lot of them do. But if the Medicaids and the Medicares, they don't put a value to it, then the insurance carriers won't pay for it. Preventative care, well care. There's no Medicare value for a checkup on a kid. So the insurance carriers can't plug in a number. So that's pretty pathetic. They should give it a value, but they don't, because most of the contracts.
But how do you value that? That's the problem, is we don't know how to value these long-term outcomes.
Well, yeah. You know, the obesity and you know, all those things, the dietary stuff, they should be paid. Yes, they should be paid. Should we be spending an hour and a half for every patient that has obesity? No, but you should set up a work plan, a workflow to be able to manage these kids, because we've already seen it in my own practice. We have one doctor that does a lot of the obesity management. So he does good quality. Okay. Great quality, superior quality, I would call it. He generates less money than me. We went to school together. He used to generate the same amount of money as me. But we, as an organization, decided that the quality is important. So he will do that. He will see less patients for a longer period of time using the same codes that I use, maybe a higher level. And in the grand scheme of things, it'll be okay. And we will be doing good for society. And, you know, it'll be fine, because there's not enough ear infections for everybody to take care of.
Yeah.
But not everybody looks at it like that. I could look at it from the point of view, well, we're partners in the organization. I generate more money than you. Why are we splitting everything down the middle? That's
Well, a lot of people do look at it, and everyone has their own, they're coming to the table with different needs and incentives, right? So if that person needed to be more productive and needed to take home more pay, then they wouldn't be able to practice that way.
Yeah, I always believe in do good quality and the money would follow. If you follow the money, you'll never do good quality. Makes a lot of sense.
Yeah.
You know? So he is doing good quality. We're doing the obesity stuff. He's having good outcomes in his obesity program. And then you expand that into other contracts, value-based contracts, performance contracts, increasing your negotiation power by saying to the insurance carrier, I need a better Medicare reimbursement rate because we have Dr. X that's doing the obesity management. He's had good outcomes, and look what's happening. So we can't work on just 100% of Medicare or 90% of Medicare. Unfortunately, the Medicaid, they don't do that. And a lot of the children have Medicaid.
Right.
Yeah.
So
what is your thought, Herb?
Well, I think it's we don't have a problem with quality healthcare in America, and we don't really have a problem with access to care in America, except if you're in very rural or very urban sites where it's very dangerous to be. The problem
I agree with that, but we can talk about that later.
But the problem is the way we finance healthcare. So Medicaid is a joke in most states, and it undervalues the care that pediatricians and internists and family doctors give to patients with Medicaid. But they're happy to say, you have insurance now. No, well, you have a government aid program that pays so little that in Virginia, 50% of pediatricians can't afford to see Medicaid patients. So you can go to the emergency room and, you know, maybe a federally qualified clinic. The second problem we have is this crazy idea that came about in the Second World War, that they couldn't raise salaries. So instead they added health insurance to the employees, and it is a non-taxable event. So the customer, the person using, has no idea how much that company's paying for their health insurance. So you take a car guy in Michigan making 60 grand a year, and GM's paying $30,000 a year to insure their family of four. And it's zero co-pays, no, prior auth. They can go wherever they want. And he or she has no clue what that's costing. And they never pay taxes on it. They're just like, that's what my union negotiated for me. That creates the same setup that we have with the failing public school systems in America. So when you sit down to negotiate, it is the health insurance plans who benefit every time that the premiums go up, because they get 15% of all the premiums they collect. And on the other side of the table are the nurses unions of America and the health systems of America. And neither one has skin on the game. So what happens is, I'm a big health system, Stanford, and I say for an MRI, I'm going to charge $2,500, Blue Cross Blue Shield. And Blue Cross Blue Shield says, well, no. And I'll go, oh, who else is going to do that MRI in this regional area? There's no one else to do it. You think the employees at Apple's in United Healthcare, but you think the employees at, blah, 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 are going to be happy because they can't get their MRI at Stanford? And they're like, no, okay, we'll pay that. And they go back to Apple and go, well, premiums went up by 15% because that's what the cost of insurance is. So like the school systems, they don't have any skin in the game. They don't have any reason to think about quality. They don't have any reason to think about cost, because I send my kid to the school. No one charges me anything. So I get what I get, right? And that's the same thing with the person that's insured through their employer. They never see what it costs to be insured. And so I have no co-pays. I'm going to go to the doctor 10 times and the ER twice. What do I care? It's a benefit of my union provides for me.
Yeah.
And then the negotiations totally out of kilter. And in America, the politicians lack courage, and they haven't been able to come around to having the conversation of we need to invest in preventive and early detection, and not just in expensive treatments. And they're all complicit. The American Academy of Pediatrics recommendations on obesity that we give a $1,600 a month shot to everybody that's obese, which is up to 40% of kids.
Yeah.
And they might say only BMI above this, but honestly, this is very politically incorrect, but honestly, you're going to deny the 14-year-old Black kid who is BMI of 85% and wants to lose weight the medication? No, you're not.
Yeah.
You're going to say they're going to think I'm racist, that I'm discriminating against her, that it's not equitable, that's this, that's that. I'm going to write the prescription, and if Medicaid pays for it, Medicaid pays for it. And if they don't, the family's still going to like me. And is that the solution for obesity? That's $20,000 per kid per year for the rest of their lives, with one single study that had 200 patients and 1 year follow-up. And everybody knows from the adult medicine, once they stop taking the medicine, they regain the weight.
Yeah.
So again, could we think about ways of helping children not be obese? Yes. Should it cost 20 grand per kid? No, but it's very easy. Here's a drug. Everybody's happy. The doctor prescribes it. The family's happy. Where's the money come from?
Yeah. Yeah. I can see where you stand on that issue.
I think if the patient comes in, we've had a lot of success with my associate, Dr. Riley. He has a full obesity clinic in a private practice without a million tests, without a million specialists and consultants. And he's had positive outcomes.
Right.
He's done the right thing. So we use the obesity program as leverage to negotiate better insurance rates, contracts. So the quality fixing the money.
Yeah. So
But
what if you go even earlier though? One of the things that I think is underappreciated about pediatrics is that a lot of what I did in clinic was teaching families how to feed their babies, right? Which includes, how do you feed yourselves? How do you put family dinner on the table economically and efficiently. And all of that requires behavior change on the part of the parent. So when I think about obesity, I mean, so we could think about it in terms of obesity treatment, right? Which a large percentage of kids need that. But what about the ability to do that upstream more, to take the time to actually do the type of counseling, behavioral support, nutritional support that families need early on? Have you seen any practices that are able to do that and be reimbursed for it?
No. Yes. So Jim at RBK Pediatrics has a wonderful video on not doing sugary drinks. And, his point is always when that parent comes in with a 2-week-old and says, does the baby need extra water or maybe some juice at some time? His answer is never. Breastfeeding and formula is all your baby needs. When he graduates a little more, he can have water. He doesn't need any sugary drinks the rest of his life. Right?
Yeah.
That's where it starts.
Education. He's starting with education.
With education, right?
Yeah.
And he does it in the exam room, and he does it, through videos.
Yeah.
And does he get paid for that? No. Zippo. But like George says, because they're not owned by a huge conglomerate, they're concerned, they're part of that community. They've been there for over 50 years. And they're concerned with the quality of care they give their community. They are part of that community. Once you detach yourself from the community, you're just part of it, this huge, that's why the federal government doesn't work very well. They're all sitting in nice restaurants in DC, 20 minutes from my house, enjoying life, and they have no idea what on God's earth is going on in Alabama or Louisiana, or some of the neighborhoods in LA, or some of the neighbors in Chicago. They never get there. Yeah. They're too busy living a good life. And that's what happens when a doctor goes to a huge health system. He's just now following orders from someone who's concerned about the money, the metrics that, how many visits you're seeing, how much money we're making. Is that the department failing? Is the department breaking even? And that's all they're concerned about. And then they get in their car and they go to a nice neighborhood and that's it. That's all they care about.
So can we back it up a few steps and talk about some of the practice models that you guys have highlighted, and which ones you think are working best in the current system, which ones are maybe even reimagining how it could be? I wonder if you can highlight some, or maybe let's just start by, in terms of the general practice styles, or the business of pediatrics, or the business models. Can you categorize them?
Well, I think most pediatricians want to do the right thing, all right? And I think the Bright Futures and AAP, they have a nice academic, you should do this, this, and this, and they brainwash, or they embed all these things into physicians' brains that they have to do all these things at a visit. It takes a long time. Then they come to an office. And then, oh my God, I got to see 20 patients. How am I going to see 20 patients? So, because they don't know how to get out of their own way, I think, because they have, 26 different things that they got to talk about. The problem is you cannot spend an hour with every single patient. And truthfully, I don't think I want to spend an hour with Dr. Bravo in a room talking about eating and stuff. It's boring.
And the patients don't want you to spend an hour.
So you have to find the efficiencies, work plans, something that works. What we did, this is Dr. Bravo's brainchild, is why don't you make anticipatory guidance, little video snippets, and things about vaccines, what vaccines are to be given at every single visit. So we send a little video, a little text message to every patient. The doctors of RBK would like you to watch this video. And in the video, we have two physicians, myself and Dr. Scott, younger generation, where we talk about at every visit, you should do this, you should do that, you should safety, and so forth. Talk about different viral illnesses. He'll ask me, so in your experience, Dr. Rogu, did you ever see measles? Did you ever see chickenpox? And of course, I'll say, yes, I did. We treated it. We had this, telling them stories. 3-4 minute videos and everybody watches it. You did all your anticipatory guidance, you did your job, and in the room, you can talk about whatever you think is appropriate. If the kid's drinking juice or something, say you don't drink juice, or if she leaves them on the table unattended, tell them don't fall off the table. Common sense stuff. So a relationship dialogue, not a didactic, I'm talking down at you dialogue that takes 2 hours to do, because it will never get done. But the physician will be happier. He'll be more efficient for the practice. They'll get out of the room faster and everybody will be okay. But it's all efficiency. And most physicians are inefficient.
Yeah, and what do you think that is?
Regulation.
Regulations, computers.
HIPAA's a joke.
Yeah.
EHR was foisted upon us when it was not ready for prime time. It's still not ready, although there are workarounds which are making it more productive. There's MOC is a joke. And the general idea that the lawyers who write the legislation put on the public is physicians cannot be trusted. They cannot have, they have to be, we have to have Stark laws, self-referral laws. They can't unionize, they can't talk to each other because they'll collude on the pricing. We need to police them. They can't receive a pencil or pen from Pfizer because they might give you a vaccine in exchange for that pencil. I mean, it's basically offensive, but yet they go out, and I'm not complaining about Justice Thomas, I think it is. But he can go on a $500,000 vacation with his friend who paid for it. And that's okay because the lawyers can be trusted. Yeah. But I can't be trusted to take a pen from a pharmaceutical company because I might prescribe something for a kid, something that costs what, $100? Are you out of your mind? And, all this regulation handcuffs you, like you're saying. Like, why do I need to bring somebody in the office to see how they're doing? Because otherwise I spend the whole day on the phone and not make a dime. But your lawyer, your accountant, any other professional in America can pick up the phone and say, hey, Herb, I need you to bring this and that to finish your tax return. Could you send it to me through DocuSign? And you do. And, my lawyers send me emails, and there isn't anything more important than the lawyer-client relationship. But they're not bound by it has to be encrypted and you could get fined this much if it lands in the wrong desk. Oh, so what? So when you make a phone call through a regular phone, if anybody has a regular phone, that's not encrypted. Anybody could tap that. When I send a letter to someone, anybody could open it and read it. That's not encrypted. So
or a fax machine for that matter.
The fax machine is not encrypted. Right?
But so then how do you explain the disruption that's happening now, where because we haven't been able to service patients, these digital health companies are coming in and doing it for us?
Because they can.
Because they can. And second of all, because you are beaten like a dog till you have no hope as a physician in America. And so every time I talk to physicians about you need to do A, you need to do B, or you need to do C, they go, oh, but that could be seen as colluding. Oh, but it could be a HIPAA violation. Oh, but the AAP said, oh, but my medical board might object to that. So you can never do anything differently. And so we're seeing patients minus the HR, which is horrible, and the electronic scheduling appointments like we did back in the 1950s. One at a time in the exam room with a stethoscope. And so we can't change.
But so you're describing a population of pediatricians who are disempowered, it sounds like.
They've been disempowered 10 years ago.
Right. So I guess the question is, to what extent is that maybe the culture or the type of character that goes into pediatrics, sort of conservative, right? We take very seriously any test that we do on children for fear that it will cause a problem. And to what extent is it, as you said, external factors? That's what I wonder about.
Well, that's why we created the podcast, because I think is we stop talking to each other. We stop listening to each other. We stop acting like a community, and we allow the health plans, the legislators, and the hospital administrators to decide for us what they're going to do.
Yeah.
And we just do what we're told. And it's miserable because I'm not saying they don't mean well. They obviously mean well. You know, I think there's very few legislators that are totally kooky that, you know, mean to harm any segment of the population. But they have no idea of what they're doing with that pen. Zero. And I mean, even Obama, Obama thought EHR was a great idea, which if you think about it, yeah, of course it's a great idea. I can go to any ATM and withdraw cash from my bank account, which is not even in that bank that I'm withdrawing the money, and I can be in China. So why shouldn't healthcare run the same way? But it doesn't. You know, it's a lot more complicated than withdrawing money from your ATM. So until these regulations are adapted to what the customer wants and the time that we are in, it's not going to change. And it seems like the academic centers love to add bullet points to everything that a physician does. And the honest truth is, most parents, when you walk in, and this is what I do, I ask, what questions do you have for me?
Yeah.
What is it that brought you here today? Because that's really all they want to talk about. And then once they're done talking about their concerns, then you can give them an instruction sheet or a video and say, this is what we expect of your 2-month-old. And these are things that really worry me if you see in your 2-month-old. And I need you to call me. I don't need to go through the whole Bright Futures and check them off, you know, because they don't have the time and they don't want to hear it.
Yeah.
But we don't have a relationship. They very much, and I hear this complaint from well-to-do educated parents and from poor parents. It's a waste of my time.
Yeah. And even the people who wrote the Bright Future stuff, they themselves say it's impossible to do in a visit.
Yeah, I have a talk that I give to digital health companies that outlines what we need to do in a visit, and makes it very clear that it's an impossible task.
It's about just clicking those things.
Yeah.
So, you know, the EHRs have a listing of the different things, and you as a physician should go off on different tangents and talk about different things that you feel are appropriate for this particular visit.
Yeah.
You know?
Yeah. I just want to reflect something to you guys, just because I'm having the same feeling that I had a little bit when I was in practice. I think I always felt a little bit like the maverick in the group, and and sort of always trying to problem solve, couldn't really understand the barriers and tried to navigate around them. And then as I have spent more time with digital health companies and health innovations that are targeted towards children and families, it's apparent to me that that's the polar opposite, right? And so then the conservative side of me comes out and says, well, what about this? What about the pediatric medical home? What about follow-up? You know, all the sort of things that we say. But I think the piece that's troubling me is that there probably needs to be some marriage of the two. And so I'm interested to understand how you two think about that. Can you move fast and break things in healthcare? And to what extent can we do that in pediatrics? Because it's sort of already happening, right?
So I think to your question, right? So George has one word that he says over and over again: relationships. And the reason that they're big super groups is because they're very focused on the relationships, and they have partners. So the partners, like a marriage, a good marriage, complement each other. And George is a very curious, constant learner, while Jim is
Academic.
more academic, more conservative. Show me the data, show me where's that. He needs to understand why this is going. So it balances things out. And in the podcast, George is more reserved, and I'm a bullet train with 2 machine guns on top. I don't take prisoners. And George can tell you our coaching meeting this morning, right? It was an hour where I just basically fired at everybody and told them what I want done by the end of the day. Because we need to move. We can't just talk about stuff. It needs to get done, and we need to get it done now. And that's just who I am. That's why I don't fit in the health system, because
you would be fired, number one.
I am a disruptive physician, because I walk up to the CEO's office, knock on the door, and like, you don't have an appointment. Like, I need to see him now. And I walk right in and I say, look, you can't be doing this, because someone's going to die, and it's going to be a kid, and it's be really bad for you. You're going to get fired along with me. Want to go for that ride? And you bet he picks up the phone, or she picks up the phone, and chews somebody out below, and the problem gets solved. But after about the 7th time you do that, they start looking for a way to make you leave, because you are making more work for them.
Yeah.
They want quiet, steady bonuses.
They want sheep.
Yeah. So yes, we need to disrupt. How are we going to disrupt? I think it starts with educating young physicians. And I mean young physicians, medical students that are interested in pediatrics, teaching them finance of their own households, so they're not, up to their eyeballs in debt, and how to run a practice. Because I do think, like George, that the best practices are physician-led or physician-owned. And if you let go of that, then it becomes all about the money, and the innovations about how to improve the margins, not how to improve care. But we have fallen, because and I know why we are. I tell people this all the time. If I did anything that Cosmopolitan magazine says on your kid, I'd be a witch doctor. I wouldn't be a physician. So we're trained to be slow and cautious in medicine, to look at what our forefathers did, what worked for them, what didn't work for them, and to follow in a conservative way, and not to change practice until we have the studies that prove that it improves outcomes.
The problem I have with that is, I don't know your experience, but my experience in COVID is that families were drowning, and it was really difficult to be a child health advocate during that time and be seeing families. And so it actually felt to me like there's real urgency, and we cannot be conservative and wait for data. There are ways to be thoughtful, responsible, and evidence-based without waiting for randomized controlled trials on every single detail, right?
Right. So tell me, what did you do? You were in a practice, I think, at that time, right? During COVID.
Yeah. So I was
what happened? Tell me about your practice that day, and I'll tell you what we did.
Okay. Well, so we were a community practice. Most of our patients, our families were in network, meaning they were employees at Stanford Hospital, 2 working parents away from their extended relatives. So when everything closed, literally everything closed, and we were part of we were just one small pediatric, or 14 doctors, but pediatric practice in the setting of a large adult multi-specialty group. So the prioritization of peds in general wasn't great, right? I think we were sort of viewed as a referral base, essentially. And so when everything closed, I think the adult doctors felt comfortable with that, because adults had access, I think, to the emergency room, and I guess that felt less, well, I can't really say what that felt like, but to me, when I'm speaking on the phone with my, my first responders who are going to work and their children have a fever, it didn't seem right that they should go to the emergency room. And so I led our practice's COVID response, and again, we didn't have recommendations, and I we were waiting for, remember those days we were waiting for papers to come from China or something to describe the virus. What does it look like? I was reaching out to the infectious disease folks. I was reading past papers on epidemics and pandemics and how those were handled. And so we designed a COVID clinic actually in our practice and continued seeing patients the whole time. And it was just a series of really exceptionally difficult administrative challenges.
Yeah, well, we all had that problem.
Yeah, so tell me
You
about
guys-
how your experience.
So
So
you guys
before-
closed.
so
A lot
George-
of them closed
George,
down, right?
Before you go there, tell me about the kid that you, Sabrina, that you met in the parking lot with a fever,
Oh gosh.
and what happened the next day? Because I think that exemplifies corporate medicine.
It really does. And it was the nail in the coffin for me, quite frankly. So, so I had a full day of clinic, and my wonderful nurse came to me at the end of the day. She'd been putting out fires all day. And she said, this mom called at 8:30 this morning. I just haven't been able to get back to her. Baby has a fever, 2-year-old, 18-month-old, something like that. And I said, fine, it was like 6 o'clock. I was trying to get home for family dinner. I'll call her from the car. So I'm driving home, I'm speaking to this mom. It's clear to me that this child has a fever. If the child is not seen and checked, for instance, for like an ear infection, then that kid's gonna end up in the emergency room. So I said, all right, well, meet me in the parking lot. The clinic's closed, but I'll examine the baby and we'll just keep you out of the emergency room tonight. So I turned around and went back to the parking lot at our clinic, examined the baby. What I told the mom is now almost 3 days of fever. I said, if the baby still has high fever tomorrow, you need to come in and we have to do a urine, and so call our office. And so I went back into the office. Everyone was gone. I sent, the way you're supposed to do it. I sent staff messages, I charted, and I left Post-it notes, which is the ultimate way that we communicate in medicine, right? So in addition to all the formal ways of communicating, I put Post-it notes on my nurse's desk, saying, FYI, I'm not going to be here tomorrow, but this patient may be calling or may be coming in if they have fever. And so the next day I start getting frantic phone calls from people in the clinic saying, this mother just walked into COVID clinic with a fever, which, by the way, I designed the way that we get into clinic, so they couldn't have walked in with a fever. I mean, they certainly could have been triaged at the door, but regardless, I think the mom's impression was, my baby has a fever, I'm bringing them in. And so that was their first issue. And then they just couldn't figure out how to get this kid in for catheterization. And ultimately, I don't know, 5 or 6 people ended up calling me, everyone with ruffled feathers, for a problem that struck me as really very simple. We'd done visits for catheterizations regularly. And then ultimately there was an investigation that was launched by HR to look into how something like this could have happened. And what that told me is that I can leave my family dinner and do what I think is best for a patient, but the system still can't do what's right for the patient.
Correct. It's called bureaucratic medicine.
Corporate medicine.
Corporate medicine. So what we did it all. We didn't shut down 1 hour. All right. We put people that had vacation on vacation so they didn't lose money. The other people that were around would see the patients. We saw everybody. We divvied up the office, well side, sick side. We saw people with fevers. We saw people. We did COVID tests. When it was time to get COVID test, we got the COVID test. When it's time to get the COVID vaccine, we got the COVID vaccine. We just saw a problem and we resolved the problem.
And you saw people in tents,
Yeah.
right? The parking lot.
So fast forward, everybody's talking about, oh my God, people are vaccinated. They're going to be vaccine delayed. They're not coming in for the checkups. We started to smell that people don't want to come into the building when they're healthy. What did we do? We went to Costco, bought an 8x8 tent, put it in the parking lot. We did a telemedicine visit with them from my office. So they're in the car. You do all your stuff that you got to do, order all the stuff you got to order, give the referrals that you need to do, give all the refills that you need to do. Then you say, I'll meet you in the tent. You go into the tent, you examine the kid, The nurse comes afterwards, give them the shot, interaction, 3 minutes, 5 minutes, however long it took outdoors. Was it great medicine? No, it wasn't great. I mean, it was good enough. It was better than nothing.
Yeah, but it was necessary.
It was third world medicine,
Yeah.
but it worked, you
And it
know?
was better than the emergency room.
Yeah, better than the
Yeah.
emergency room. We never sent anybody to the emergency room.
Yeah.
So,
You
so
know, we saw them in the
Sabrina,
office.
when you tell that story, the first thing that comes to my mind is I love you. You are what I think of a doctor. You will drop dinner with your family to take care of a patient. You will answer the phone call. You will go home and worry about the patient. You will do what's right for the patient. You're just in the wrong place. You're in corporate medicine, and corporate medicine doesn't value doctors that put the patient first and foremost and humanity in the exam.
Right. Thank you for saying that. But I actually think, I mean, I'm not in that practice anymore because of that and many other experiences like that. But what I am doing is at Stanford focused on reimagining how we can deliver pediatric care so that it puts the patient and the family in the center. And so I look at practices like yours, Dr. Rogu, and say, what does the future look like? So right now you have the skills to run this practice.
Yeah.
Do you think it's sustainable? Tell me about the business of your practice and how you think it's going to translate into the future.
Well, you know, back in the COVID times, I had the Dr. Rogu part of me that had to do work, right? I had to take care of the patients because I thought it was the right thing to do. Also had to take care of the physicians, all right, because they're our physicians. You can't put them in harm's way. We had to get them the mask and all the stuff that you need. And then besides all the medical stuff, practice owners, we had to sustain the practice. How do you generate income if people are not coming in? How are you going to pay all that vacation time? So you have a lot of hats.
Can most doctors do that, do you think?
Most successful physician owners do that very well. And where
do you think they do? That hasn't been my experience. It feels like those are two really different hats to wear.
most successful physician owners do that very well. And we hear it over and over and over and over again, how happy they are, how well they do, you know, how satisfied they are with the care they give.
Yeah.
But you have to want to, you know, it's not easy.
It's not easy.
And where we have fallen short is we have not educated younger generations of physicians, again, including medical students, on how to run a practice and how to run a business and how to finance stuff. And that is one huge opportunity.
Yeah.
You know, because you're right. So George has a younger brother as a partner, and he has a son in medical school. So it's a family business, right? So everybody's learning the ropes as they come up on the food chain of the family business. But if you don't have a younger brother and a son that's in medical school, then you have to hire physicians that want to make a difference and are willing to roll their sleeves up, run a practice, run a small business, and start teaching them from day one.
Yep. I have medical students that come with me every month for 10 months. I have a different student every month. I got tired of looking for physicians, so we figured we'll grow our own. There has to be a kid from Long Island that goes to this school that's going to go into peds. You know, I have 10, 4 other doctors have 10. So there's 50 bodies that go through our building a year. Somebody's going to go into peds and want to go into private practice, and we're teaching them. And our practice rotation has become the most popular rotation at their school.
I can imagine that. That sounds amazing.
And I mean, let me just share some of the success stories that George has had, right? So we do some data analytics, and he had a student who is, of course, this is so racist to myself, but he has to be South Asian. He's an engineer, and the kid's a whiz at math. I mean, just a whiz, and now is going into medical school or is in medical school, right? And he looked at some of our dashboards, and this kid could not stop playing with it. He couldn't believe that a small practice and, quote unquote, a pediatrician understood data and could program software to show the data that a practice needs to run.
Yep.
And he had the best 30 days of his life.
Mhm.
He was learning pediatrics and he was using all the math he learned in engineering school.
Then he got a mini MBA.
He got a mini MBA, so much so he said he might come back for another
He might
rotation.
come back. He's coming back as a 4th year, and he may even go into pediatrics. I don't know, but I told him if he does, he's welcome. And he's from Long Island.
Right?
Look, I feel like there's an elephant in the room, which and I would love to get your 2 cents on this, but I do a lot of work in the digital health space. I talk to a lot of founders. Mainly they're entrepreneurs or tech-oriented people who had the experience of becoming parents and realize how difficult our system is. And so I've created solutions for children and families. And my observation is that they are getting traction with families, because it may not be the case in your practice, George, but in the vast majority of practices, I think that families and patients in general find it difficult to reach their doctors, difficult to get questions answered, difficult to understand what needs to happen.
Right.
And so there's a need, right? So these companies are going direct to consumer. And my fear and my anticipation is that it's going to cannibalize somewhat the pediatric medical home and the relationships and expertise that we're able to offer families. And so my thesis has been, we need to work with them and collaborate to the extent that that's possible. But I'm curious how you 2 think about this.
Herb, take a stab.
I think everything starts with humanity and relationships.
Yep.
If there are tech platforms which allow me to quicker and better communicate with the families of the kids I take care of, that is that helps the problem.
I would call that physician enablement, right?
Yes.
Like tech-enabled solutions. Yeah.
But if it's something that is sold as a solution to a problem, technology is hardly ever a solution to a problem. It helps or enables humans to solve problems.
Right.
But
I don't disagree with that.
we're never going to replace relationships with machines.
Never.
No, but we can power them, don't you think?
Yes. And
Yes.
that's where the money is going to be, is to create solutions that make it so. So I always give this example. I don't need to see a backup throw culture being negative and sign off on it in an EMR. It's a waste of my time. I don't need to see a negative urine culture. It's a waste of my time.
Yeah.
When I had the urgent care, my nursing staff would sign, date it, call the parent, and put it away.
That's efficiency.
We already
That's
had an
efficiency.
We already had an EMR, so they noted in the EMR, urine culture came back from Quest, negative. Call the parent, child's doing better, right? Well, we could do that with AI. I don't, it drives me nuts when I go in clinic on Fridays and I go through 30 negative throw cultures and urine cultures. Why am I wasting my time on that? Let me spend that time taking care of someone else, right? So definitely, if you could find AI that does that, why are physicians coding? It's a waste of my time. Let me spend those extra 2 minutes with the patient.
Well, I would argue that there are many more things that we could use technology to augment.
Yes.
Aside from those, but that the essential problem for pediatricians is that there's no bandwidth. There's no bandwidth, A, to co-develop them, and B, to integrate them into our workflow. And I've seen this played out in conversations with founders over and over, that they find it impossible to reach pediatricians and to be able to co-design and collaborate on their innovations. And I remember being in practice, you're seeing 25 patients a day. There's just no time to breathe, much less to find and validate a new tool in your existing workflow, right? So how do we solve that?
Well, I think you have to start like how we started, right? So we have a CEO coaching class. A lot of great ideas come out of there, right? But it starts with a relationship and a conversation. If you want to get founders with pediatricians who are one, tech savvy, and two, willing to test different things without breaking, nobody wants to break their train, right? Because that's how you make money. But they will try things that, might improve the timing of the train. They just are going to say, if it's going to totally stop, we can't do it. But these people have to get together in a room and have a mastermind and understand what the friction points are on both sides, and then come back the next day and do it for another 4 hours. And again, understand what the friction points are on both sides, and see who develops a relationship with who, that they can collaborate on, a project. And unfortunately, there has to be money on the table, because doctors make money by seeing patients. They're not in the dream world of a lawyer where I'm going to win a $20 million settlement and 30% of that is mine.
Yeah.
They're not in the tech space where if I sell this company for $5 billion, 500 million of that is mine.
Yeah.
We see patients every day, but it's doable. George has done some tech experiments in his practice to help, corporations they're starting technology and using it.
Yeah, George, can you share some of your experiences with that? Have you done pilots?
I get called on advisory boards for everybody for some reason. And everybody thinks that they have a great thing, but sometimes it's not practical. It's not usable. It'll get in the physician's way and the doctor won't use it. From telemedicine to EHRs to different interfaces and platforms, front end, back end. I mean, they always, many times with a product or something, you'll get a company that wants to implement the product in your practice. The doctor will say, go talk to my manager. The manager will decide whether that product is good for the practice, for the doctor to use. They do everything, they do all the work, they pay all the bills. Then the doctor gets on board. Oh, this is no good. I'm never going to use it. Be gone. What a waste of time, money, and effort, because he did not get involved. He should have gotten involved a little bit, looked at it. He would have realized in 5 minutes, this is garbage.
Yeah, so but you had
to come out of the exam room, come out of the silos. Did you notice how many times we said the word relationships in this podcast today? I'd say 20, 30 times. That's what's missing. And I think corporate medicine is trying to destroy relationships in all domains.
Well, but corporate medicine is different to startup medicine, which is the other piece that's happening.
Yeah.
So George, you had a good experience when Pedro and Canet came and they tested their vaccine product.
Yeah, no, they had that experience was they wanted to develop a platform to manage vaccines. And the way to do it was through COVID, because everybody wanted COVID. So they came to me to help work it and put it into our office. So I expected them to have a product already developed and fully operational. Little did I know that the tech companies usually develop it as they go along. So I helped them to develop it as they went along. So we had the patients, the this, the that. And over time, they made a really good product. But a physician wants that product to be fully good the moment it hits my office. I don't want to build it for you.
Yeah.
So that's where it's different brains that are working. The tech company where they develop it as they go along, and the doctor that wants it perfect.
And so why did you decide to work with that company?
Because I thought it was the right thing to do. They were doing a noble thing with COVID vaccines. They helped us to develop for our clinically integrated network to be able to get a lot of the Pfizer vaccine, to take it and to redistribute it to other smaller practices within our clinically integrated network. So they did all the tech inventory and the management of that and helped to connect to the state to get it approved. So where we could either say, oh, there's too many vaccines to give, so we can't give COVID vaccines, or we can do something about it. So they wanted to do something about it. I wanted to help. We got it together. So in my community, in our clinically integrated network, I can go down and say, we did the right thing and we gave vaccines to children.
So would you say that there are other problems similar to that you would be interested in collaborating on a solution to develop?
Oh my God, you know how many podcasts we can make with this?
Well, that's what I'm interested in, actually.
Oh yes, so
I
many.
think there are many opportunities for this, but I think it's hard to reach pediatricians because we're so busy.
Yeah.
So I have two thoughts. So another pain point in this discussion is that a lot of these tech solutions don't integrate with these smaller EMRs. And so you might have the most beautiful tech solution, but it's just a totally other silo. And then it doesn't work with an EMR. Or, you know, the hospital here is ECW with Children's National. Well, Children's National doesn't want to spend the money to integrate it into ECW. So it just creates more work for me, for my staff. And that's always a big point. There's lots of great solutions out there, but they live in a different silo than my EHR. And so that's another pain point for the practice to incorporate.
Yeah.
And that's a really difficult one to crack, because the EHR companies, they want to make money. And so they focus on the problems that will make them money, not integrations.
Well, that's a good topic for a podcast right there. We should do this once a month.
But
I think EMR integrations is a very interesting one, especially as it relates to pediatrics.
yes.
Yeah.
So I think it'd be a great idea if you wanted to do a podcast once a month, Sabrina, with us, focused on innovation, and invite your people from Silicon Valley.
We'll make your topics.
Yeah, I'd love it. I'd love it. You guys, so here's what I wonder though, after this conversation, is that you guys have a very strong point of view, it feels like, in terms of your vision of pediatrics, of sort of ideal pediatrics. And I think I'm not really sure. I think I either have my own strong view, or I'm a little less committed to one. No, I think I'm just a little less committed to one model, which I know is sort of like apocryphal to, you know, the pediatric community, that there should be anything but this one model. But I don't know, I'm really interested in exploring how we can empower this relationship between pediatricians and patients, but decrease the friction to getting all the necessary data and analysis that we need.
Right.
So is that something that you guys are open to?
Yeah, sure.
Yeah.
Yeah.
And
again, it starts with community, right?
Yeah. And relationships.
You're not going to solve a lot of these problems unless you're part of your community of relationship.
Yep.
The further you get away from the community and the relationships, the less effective you become if you're trying to help people.
Right.
Now, if I'm just trying to make money on Wall Street, doesn't really matter where I'm sitting. You know, I have a computer with 5 screens, and you know, I'm screaming every time, you know, one of my bets goes down. But you know, there's no relationship between me and my Apple stock. You know, that we don't talk, we don't go out for coffee. Apple stock doesn't tell me about their kids. No, but we're in a relationship-driven business, and we're in a community-driven business. And as soon as we get too far away from that and lose our humility, we're done.
Yep.
I agree with that. Can I just share one last thing?
Yes.
I want to share an example, because I just think it's a good illustration of how these digital health companies can actually be really beneficial. When I was in my practice, being in Silicon Valley, my patients are early adopters. I'm an early adopter. And so they were always bringing things, solutions to me, and I was always learning about things and trying them out with our patients. And there was one in particular called Kerbo Health. Do either one of you know that?
No.
So it was started by a local woman in Palo Alto whose son used the Stanford Pediatric Weight Loss Program, which is very labor intensive. The family needs to come to clinic on the Stanford campus once a week for, I forgot how long it is, but for a significant amount of time. And he benefited greatly from it. And so she's an entrepreneur. She said, well, how can I make this more accessible to more people? So she licensed their evidence-based weight loss program for children and created an app called Kerbo, which she then augmented with weekly coaching. That was sort of an add-on service. And so I heard about it early on, and I started offering it to families sort of as an add-on to conversations when that was a topic of conversation in our visits. We would look at it together and say, is this something that would be interesting to you? And by and large, the teens, the adolescents were incredibly interested in having something they could engage with on their phone, something that would give them guidance on how to improve their eating habits. And the story of Kerbo is so fascinating because I actually interviewed her already for my podcast, but she found it difficult to be funded. And she found it difficult to collaborate with pediatricians because, again, they were so busy. And the funding piece is that the majority of venture funders didn't get it, didn't really understand why what the value prop was here for families. And ultimately, she sold it to Weight Watchers. Okay. And you may have seen in the press, there was an enormous backlash once that was announced that there should be any sort of weight loss interventions for children. And it's a cautionary tale and an interesting story, I think, about all the different unique barriers to creating something good for children using technology.
Yeah. But it can be done.
It can be done, but
you just have to get the right people in the room.
Correct. Relationships.
And it's not gonna be one time, it's gonna be several times.
Yep.
Until people come up with, they build trust, they build relationships, and then, they prove that things work.
Yeah. All
Well,
right.
this has been a wonderful hour. Thank you for guest hosting. And
thanks, guys.
We'll pick it up again in a month.
Once a month.
We'll pick it up again in a month.
So do you want me to bring other guests on, or how do you want
this is going to be
your good. Bring anybody you want.
Your show, and we'll tag along for the ride.
Okay.
All right.
Yeah, will you send me feedback later, guys?
Yeah. I'm gonna let this parse, and I'll send you the file. Okay.
All right.
All right.
Takes about an hour or so.
All right. Bye, Sabrina.
Bye. Thanks. Bye, guys.
Bye. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.